Thank you. So I'm here to talk about anxiety. What is anxiety? Is it a bad word? Is it useful? Well, it can be. It can help us pay attention to our surroundings and get us out of danger. By understanding it, that can lead to a sense of mastery and personal growth. These are good things, right? But when it exceeds its helpful role, it can be problematic. When this happens, anxiety is commonly described as worry, inability to relax, and physical discomfort. But look a little closer, and you will find fear. It can dress up for the party in a number of ways, but when someone is describing symptoms of anxiety, start thinking about fear. Your goal is to try to understand where it's coming from, study it by experiencing it in a new way, and that will help reduce its power. These are all examples of anxiety disorders, so try to think about what someone experiencing one of them might be afraid of. Separation anxiety, specific phobias, panic disorder, agoraphobia, post-traumatic stress disorder, obsessive compulsive disorder, and generalized anxiety disorder. Which one do you think is the most common? It's actually not generalized anxiety disorder. Specific phobia is the most common anxiety disorder. About 7 to 9% of Americans have a specific phobia or severe anxiety-related response, fear, to a specific object or situation. Most people with this actually have this fear around 3 different things. This can include animals or insects, environmental stressors such as storm, heights, water, blood or medical procedures, situations such as flying, elevators, or enclosed spaces. But today I really want to focus on generalized anxiety disorder, which is commonly seen in primary care and affects approximately 7 million Americans. That translates to about 2 to 3% of the general population that describe symptoms consistent with this disorder. I want to emphasize 3 things. First, because this can be an excessive and persistent worrying that interferes with many aspects of life, it can actually be chronic and debilitating. Secondly, it's treatable, and there's many options for treatment. And thirdly, because avoidance perpetuates the symptoms of anxiety, all successful treatment involves decreasing avoidance. Most importantly, delivering a therapeutic dose of hope is an effective strategy to help reduce symptoms. So we think about generalized anxiety disorder when we see persistent or relentless worry that's difficult to control for at least 6 months and has at least 3 of the following symptoms: increased muscle tension, restlessness, easily fatigued, decreased concentration, irritability, and sleeplessness. It can take a while to understand what someone is experiencing, and many symptoms that stem from trauma can take a while to identify. So what initially looks like generalized anxiety disorder may actually be post-traumatic stress disorder, because it takes time for someone to develop a sense of safety while in treatment. Does this mean we have to wait to start treatment until we know for certain what the diagnosis is? No. By engaging with the patient, by listening to them, by bearing witness to their story, you've actually already started treatment. This is because you have created an environment that minimizes fear and maximizes positive neurochemistry attachment pathways in the brain. Through human compassion, attachment pathways can be stimulated to grow and heal. This allows the person seeking treatment to take a risk in forming a new bond or attachment. The brain is capable of continual adaptation. Successful treatment, a nurturing relationship, and psychotherapy triggers the genetic expression that allows for decreased stress, improved learning and provides a roadmap and model for new and healthier relationships. Most of the anxiety disorders are effectively treated by both antidepressants and psychotherapy. Both of these approaches have merit. I frequently observe that after someone has begun treatment for anxiety with one of them and they experience a slight reduction of symptoms, they're more open to adding other methodologies. What medications are effective for generalized anxiety disorder? Antidepressants are first-line treatment. You can expect a 60 to 70% response rate. That is great news and underscores that anxiety is very treatable. All of the SSRIs can be effective, and choosing one is based on 3 things: medical history, side effects, availability, and cost. To avert side effects, start lower on the dose than you would, for example, if you were treating depression. Titrate the dose up slowly and see the patient frequently for follow-up. Now, although paroxetine and escitalopram are both FDA approved for anxiety, the weight gain associated with them sometimes makes them less than ideal and not a first choice option. Other SSRIs, such as fluoxetine and sertraline, have fewer of those side effects and might be a better first choice. SNRIs, such as venlafaxine or duloxetine, can be effective too. Buspirone works well for patients recently abstinent from alcohol and did as well as single agent in randomized controlled trials against benzodiazepines. We'll talk more about that group later. More important than the medication chosen is the therapeutic relationship in which it is given. This relationship is a safe, physiologically calm place. In the therapeutic relationship, the attachment figure, the therapist or the physician, acts as an emotional regulator, much like the governor on a golf course, so you can't go too fast when you press the pedal. All of the medications serve to inhibit brain structures which control emotional regulation, like the amygdala and the limbic pathways. But the disadvantage to medications is that there's no skill-building element to help train the brain to process information in a different way or decrease fear. Once medications are discontinued, those limbic structures can exhibit reactivity with new stressors. So for best results, use medications with other interventions to affect long-term changes in the brain and behavior. How long do you continue medications for the treatment of generalized anxiety disorder? Maintenance treatment is recommended for 1 year. So after 1 year with decreased symptoms, discuss how the person feels about tapering down on medications. If the decision is made to taper off, I recommend going slowly and reevaluating every 3 to 4 weeks to avoid rapid discontinuation and to avoid loss of follow-up. I strongly recommend psychotherapy. This will help build distress tolerance skills and insight around helpful behaviors. Patients maintain gains from therapy long after completing it. A new study revealed that patients who had symptoms of panic disorder and were treated with either cognitive behavioral therapy or psychodynamic therapy or relaxation therapy continued to enjoy decreased symptoms for a year after ending their therapy treatment. Isn't that great? Cognitive behavioral therapy is indicated for anxiety disorders and helps patients to reframe unhelpful thoughts. Another type of psychotherapy that can be helpful is transference-based psychotherapy or psychodynamic psychoanalytic therapy. This is long-term therapy which, in addition to the content the patient brings to sessions, also focuses on the relationship between the patient and the therapist. The interactions that occur in therapy are studied with relationship to previous attachment figures in the patient's past. Many times, a feeling of anxiety can actually be a recurring feeling or repetition that has its origins in early childhood. Studying and understanding these patterns can be freeing and healing. Now, what if the patient doesn't tolerate an antidepressant? Can a drug effect rationally explain what the patient is describing? Or is it really untreated illness? It can be problematic for a patient, an anxious patient, to take medication, and they may tell you that they couldn't even take the prescription to the pharmacy, or that they took one dose of medication and had a horrible reaction. Then what? It may not be the medication. It may be that the relationship isn't therapeutic enough. A strategy I use at this point is to step away from medication and employ motivational interviewing around their stage of change, which is likely pre-contemplation at this point. Additional education is required. The anticipatory anxiety and vigilance around side effects likely represents undertreated anxiety and is symptoms of their primary illness and not actually side effects. Validate the distress. Reassure that medication will not worsen symptoms. Reassure that there are many options for treatment and there's no deadline for getting started. Patients unconsciously want to test their doctors and see if they can tolerate their distress before submitting to treatment. This makes sense because anxiety is a defensive arousal signal, and they want to make sure they're safe with you. As the patient learns to regulate arousal and tolerate intense emotions, they will begin to recognize that their somatic symptoms are actually symptoms, and they will begin to experience them differently with less distress. Resist the temptation to over-respond to frequent complaints or symptoms with dosage changes. Physical complaints may allow legitimized contact with the treating physician. This is great because it allows you to see your patient and listen to their concerns, and that should help your understanding of the treatment response. So what if the patient's on a therapeutic dose of medication and still reports symptoms? Well, sometimes augmentation is needed, especially if the anxiety disorder has been present for a long time or has very severe symptoms or is present with other diagnoses such as depression or PTSD, or if there's double anxiety disorders. So augmentation with another medication may be a reasonable strategy. Augmentations that we have data on that can help with decreasing anxiety include things like propranolol, Buspar, hydroxyzine, pregabalin, the atypical antipsychotics like Seroquel, Risperdal, and Abilify. But with all augmentation strategies, you want to avoid rapid titration without follow-up, and in general, you want to avoid the benzodiazepines. Why? These medications can actually worsen post-traumatic stress disorder, depression, personality disorders, and substance use disorders. They can be deadly when combined with opioids. They can be addictive, and patients can form dependence on them after only 4 weeks. Because of their immediate onset of action, they reinforce an unhelpful idea that anxiety must be immediately relieved. That actually increases fear in other situations where it isn't immediately relieved, so those situations are avoidant. This avoidance response ensures that the anxiety continues. Most importantly, benzodiazepines decrease concentration, inhibit learning and memory, which can interfere with psychotherapy. So if you must use them with caution for short periods of time, and consult with an expert if you have questions or getting your patients off of them. Effective individual interventions include mindfulness, breathing, yoga, exercise, and acupuncture. Breathing interventions such as controlled, slow breathing with prolonged expiration phase actually decreases physiological arousal. Mindfulness uses different networks than talk therapy. By tuning in and focusing on the present, paying non-judgmental attention to accepting the moment, this allows a different mind-body state. This enhances prefrontal cortex activity and dials down that reactive amygdala activity. There's many types of anxiety disorders. They are all treatable. Whether you or your patient chooses psychotherapy, medication, or other interventions, you can expect to see improvement. What all of these therapies, medications, and interventions have in common is helping patients to tolerate difficult and uncomfortable feelings. The most, important factor is to engage the patient in treatment and foster a sense of safety. It is important to build an environment of trust to help contain the distress from treatment and lean into those uncomfortable feelings to study them and diminish their power. Make sure to deliver a therapeutic dose of hope. By being compassionate, optimistic, and hopeful, this will decrease fear and arousal by reducing stress hormones and reduce sympathetic activation, which will result in diminished anxiety. Thank you.